Well, people with a groin disruption, they have this injury to the muscles and tendons in their groin. And the principle of the operation is to put the muscles and tendons back where they should be, so they need replacing back. Now, you can think about it by considering the 3 layers of muscle in the wall of the tummy. Now, the outer layer has an archway in that in men, the blood vessels come down to the testicle. And what happens when the groin gets disrupted or torn is that archway opens up, it gets wider, it pulls apart. What happens next is the middle layer that sits underneath that pulls off the inguinal ligament and it exposes the back layer behind it, so there's a gap. And this back layer bulges. And often when people cough, you can feel this bulge, and that's why some people call this a hernia, because they can feel a bulge. But it's not a hernia because there's no hole, it's just the muscles being out of place. And the principle of the operation is to tighten up the bulging back layer, slide the middle layer back down, and tighten up the top layer and put the muscles back where they should be. And that's how you can think of it in simplistic terms. Now, in more detail, what you have to do is open up the groin. You have to do it from the front so you can see all the muscles of the groin all the way along their length. You can then work through the 3 layers. You can find the inner layer and you tighten that up and you plicate it with a dissolvable stitch. Now, in some people, if they have a lot of tenderness over the pubic tubercle, and this is where the inguinal ligament attaches, if that's very tight, you can just slightly loosen the inguinal ligament at that point, and that's called a tenolysis of the inguinal ligament, and that takes some of the tension off and helps with a lot of the pain. So you do that and you tighten up the back layer. Then it's a matter of moving the middle layer, which is actually the conjoint tendon, which is the conjoined tendon where the 3 muscle layers come together. You pull that back down onto the inguinal ligament, which closes the gap where it's pulled apart. And then it's a matter of putting a darn over the top of this. Now, all the stitches we use are dissolvable apart from this darn, and this is very important. If you just use dissolvable sutures, they all dissolve at 2 weeks. So if you've only got dissolvable sutures at 2 weeks, the whole thing dips, it goes weak and it can fall apart. And we do see this occasionally in people who do a partial repair. People can get back to sport very quickly, but 2 weeks later the thing falls apart. So we use a non-absorbable layer, a permanent layer of suture, which acts as a scaffold to hold the groin tight and strong while the rest of it's repairing. And if you put that permanent layer in, there's no dip in the strength. It's immediately almost back to 70% of strength straight away, and it can then get stronger after that. Now, traditionally we've used a fairly big nylon stitch for this, but we've modified it recently to use a smaller, less reactive stitch, which causes less tissue trauma and less discomfort. So again, it's looking at getting people back more quickly. On top of that, then it's a question of tightening up this top layer, and then there's another, what's called a fascial layer, you tighten up before you stitch the skin back together again. And it's based on the findings at the operation. Many people will have had scans, MRI scans and ultrasound scans, and of course when you do the operation you look very thoroughly, and every area you find is torn or disrupted you will put it together in that sort of technique.